Alright, we're going to do some cases. And what happened was, and the reason I was just cutting into the last moment was last night I looked at the cases and I presented the last few years, and I thought to myself, oh, these are getting stale, at least they were getting stale for me. So then I added a bunch of new cases. And then it was difficult to get rid of the old cases. So my guess is, I got rid of some, but there's more in the slide set that we're going to go over. But this is just for kind of enjoyment, and we'll make some teaching points here and there. So tropical med case number 1. People call me sometimes with interesting cases, and this was a call-in case. I did not see this child. This physician is in Michigan, but the boy is in the country of Colombia. And it was a bit of a puzzler. So, 10-year-old boy with a chief complaint of a painful foot rash. And this past October, he noticed very small, apparently, small papules on his left foot that would fade away every 2 to 3 weeks, and then they'd come back. He has cats and dogs, and they're occasionally dewormed. And then if you look at his rash, it doesn't really look like papules. It looks kind of linear. So what do we call this?
Migraine, larva.
Cutaneous larva migrans. And what's this caused by? Rotting cat hookworms, exactly. This is the Marley and Me movie, right? And this is painful, and this is just more of an insight. So, pretty classic, actually, right? Cutaneous larva migrans, cat and dog hookworms. Give them some albendazole, it should be better. So we think it's cutaneous larva migrans. It's a type of creeping eruption caused by dog or cat hookworms. So there you go. And there's the life cycle, and it's basically the eggs come out of the dog or the cat. The dog or cat's infected with intestinal hookworms that are feeding on the intestinal epithelium of these animals. They release eggs, the eggs hatch in the soil. They want to go into the skin of a dog or cat, they go into the skin of a person, and they just kind of crawl around for weeks, causing some morbidity, but never getting to the intestinal place. And so, this is just a slide from the hookworm talk that talks a little about cutaneous larva migrans associated with wild dogs and cats. It's very common in certain areas, up to 10% prevalent in children in rural Brazil, in a study from 2009. And usually it's just annoying. It can be a problem for some people when those lesions open up and they get an ulcer and then they get bacterial superinfections. And treatment's usually pretty easy. Ivermectin or albendazole usually works quite well. So here's the thing with this kid. He got ivermectin, 2 doses. He got 5 days of albendazole. Rash kept coming back. It's another 5 days of albendazole. Rash keeps coming back. And he has a white count of 11,000 with 10% eosinophils. So it's not responding the way we think it should respond. So what are the possibilities? Someone has something that looks like cutaneous larva migrans, not responding to usual treatment. So what's a possibility? He could just keep getting reinfected, right? So he's just getting reinfected. Stop going to this beach with all the wild dogs, right? So, so he was talked to about that, the boy, and it didn't seem like there was a lot of exposure to places where there was wild dogs. Another possibility? Keep treating someone, they're not getting better. What's that? Maybe resistance, right? This is a concern in helminthology. We give a lot of these medicines for deworming campaigns, for mass drug administration campaigns. There's always this concern of resistance. Albendazole works by inhibiting tubulin formation. If you look at certain infections, like I study filaria, so I know the filaria literature a little bit, we've never shown resistance, but if you look at the tubulin gene in areas of high albendazole administration, there do seem to be some genetic mutations. So maybe we're selecting toward resistance. But no one truly believes in complete resistance of cutaneous larva migrans. That's not really a known thing. But you know, maybe this is the first case. Is there another possibility here? Sorry, what's that? It's something else. We're being overconfident here. We're just wrong, right? This is not dog and cat hookworms. Oh, and then this is the big one that we didn't mention. Maybe the medicines are no good. This is particularly a concern when people are acquiring medicine in developing countries, right? Where, a lot of times there isn't as strong of regulation of what can be sold as there is in the United States. A lot of times people, unfortunately, are purchasing, counterfeit medicines or medicines that just have become inactivated over time. So resistant, inactive medicines, reinfection are just the wrong diagnosis. So here's the thing, and this is why I started with this one. So my general point, the reason I included this, was that when you take a course like this, or you listen to like my wormy talks, I present to you the classic cases, and this is what causes it. But the reality, of course, is always much more complex. And for any disease syndrome I describe, there's a lot of potential causes for it. So on an exam in general, if you see that picture of this boy, it's going to be cutaneous larva migrans caused by dog and cat hookworms. But in reality, there's actually several different processes. There are several different processes that can cause this phenomenon. The more general term for what he had is not cutaneous larva migrans. When we say cutaneous larva migrans, we mean dog and cat hookworms. What he really had was a creeping eruption, and that is a clinical sign, and that's the sign he had, which is this progressive eruption in kind of a snake-like pattern. And it certainly includes classical cutaneous larva migrans, but other worms can do it, including gnathosomes, strongyloides, Loa Loa, sparganum, and then actually some arachnids can do it, so scabies can do this, and fly larvae are usually, they usually don't move around a lot. They usually just make kind of a bit of a papule or a nodule, but sometimes they'll move around. It's called migratory myiasis, but it wouldn't look quite like this. So what do we think this boy had? We think he most likely had gnathosomiasis. The diagnosis isn't definitive, but the chances are that's what he had. We know that gnathosomiasis is quite common in certain areas in South America, and we know that it takes a lot of anthelmintic to cure it. So I'm not going to go over the life cycle in detail, just to let you know that usually this is acquired by eating undercooked fish, and the real risk factor is ceviche. So ceviche in Central and parts of South America is what's been implicated with this. And gnathosomes can cause a variety of diseases. This is areas, we usually think of it as a disease of Southeast Asia, but it hasn't. There are areas in Africa and in Central and South America where it's clearly been documented. It's usually the larval stage that causes problems, and it can cause a cutaneous larva migrans or a creeping eruption type picture, but it can also cause a visceral larva migrans picture. It can cause ocular larva migrans. It can even cause the eosinophilic meningitis. And it's very difficult to diagnose. The only serology currently available is performed by Mathidog University in Thailand, which his serum was not set there. But typically, we treat for several weeks, and then it does get better. And he was treated ultimately with a long course of albendazole, and this went away. Okay, so just to follow up on that case, this is a traveler returns from Kenya and finds a non-tender capsule between the toes. So we see there. Does anyone know what that could be due to? Maybe you would see some little white things emanating. So maybe it's bots. In this case, it's not quite botfly, it's fungiasis. So here's a picture of the organism. And this is just a flea that inserts itself in and releases eggs. And then similar to that is botfly, which is a little different because it's caused by a fly. Does anyone know the incredible tale of the New World botfly? And that you just treat by surgical extraction. It's just a little nuisance. Does anyone know how people get infected with New World botfly? Or where does botfly in the Americas present compared to botfly, say, from Africa? Like where on the skin? Oh, good. So this is maybe a little educational. So in these infections, what happens is eggs are deposited on the skin in some way, and then the larva hatches, and the larva burrows into the skin and causes botfly infection. and then it'll live there for a while, and then eventually get to the point where it becomes an adult fly, and if you don't pick it out beforehand, eventually just leave the body. But it's painful, and there's a difference in terms of how the eggs get there. So, old world bot fly, the flies like to lay their eggs on the ground or on clothing. So maybe someone is traveling in Africa, they put their clothes out on a rock to dry, the fly lands, lays its eggs, they put their shorts on, and now they have 6 botfly lesions on their thighs and buttocks. New world botfly, which is dermatobia, is generally dermatobia, or it's the most common botfly. There's a lot of different botflies. This is unbelievable. You just can't make this stuff up. This fly lands, no joke, on the abdomen of a mosquito and lays her eggs on the mosquito. And then when the mosquito feeds on a person, the mosquito, we don't like to think about this, but she rubs her or his abdomen on our skin, and the eggs get deposited. And so basically, I don't know why they do this, because you would think the flies would just land on us. But this way, instead of risking the human, the fly just has to risk the mosquito. Now, at the end of the day, what does this clinically mean? It means that New World botfly typically occurs in exposed skin, and Old World botfly typically occurs in unexposed skin. Does that make sense? A colleague of mine, we see botfly from time to time. A colleague of mine had a case of someone with Old World, and people call this myiasis, so Old World myiasis, and the patient came in and said he had all these little nodules on his buttocks, and he didn't know, it was just hurting him, and he went into a jacuzzi for about an hour. And by the end of the hour, 6 to 8 of these larvae had just emerged because they're suffocating, and they just floated up. And he came in with this little cup filled with botflies. Now here's someone, this is from the internet, someone's trying to put Vaseline to people put occlusive dressings, gels, what have you, to try to suffocate out the larva so it'll start wriggling out. Usually they're a little fatter in the middle than their breathing hole on the outside, so you need to make just a little cut with a scalpel, but you can just do it at the bedside. And they have little hooklets and rings that kind of keep them embedded, so it can be tricky to pull them out. You just make a little, you just look at where the opening is, and you just extend your cut, like half a centimeter, they just pop right out. Okay, so I think I have a lot of slides on this case, but I'm going to go through it quickly. This is a 41-year-old woman. This case is from a while ago. This is the only case of this I've ever seen in my life, but it's pretty remarkable. So she presented to an emergency department in Virginia with a 1-day history of fever, with swelling and redness in her groin. 4 days after she returned from a safari in Tanzania. And this is what she had. And to orient, she's like, I guess she's sitting like this. So this is her upper inner thigh. Just kind of here, I guess on the groin is where this was. And this just kind of kept growing on her. Any thoughts what this could be? What if she hadn't gone to Tanzania? And she was, what? Could be, this could just be bacterial cellulitis. She has bacterial cellulitis. What else could she be? Let's say she's from Virginia and Maryland. And, it could be erythema migrans, the Lyme disease, right? Could be. It doesn't have to clear in the middle. As long as you have an expanding rash, right? Erythema migrans. How about from Africa? What could it be? Someone say anything? Well, yeah, but, not everything causes skin. Could this be malaria? Malaria does a lot of things, right? 20% of patients with malaria present with abdominal pain. That throws everybody off. It doesn't really cause cellulitis, right? It doesn't do that. So this could be a couple things. What if there was an eschar here? Let's pretend there was an eschar. Yeah, so there's a lot of things that can cause this, but Rickettsia africani, you guys cover rickettsial infections? That's actually something that can occur, and oftentimes you will present with multiple small eschars. So it could be that, but none of those were what she had. They did a malaria smear, She was given treatment for a bacterial cellulitis, cephalexin, and she was sent home. She was still feeling sick, went to another hospital. They thought of cellulitis, Lyme disease, malaria. They treated her more aggressively, covered her for both Lyme disease and just expanded coverage for cause of bacterial cellulitis because she wasn't improving. So I didn't include her past medical history, it wasn't that contributory. She did live in a wooded area in Virginia, so she was certainly at risk for Lyme disease. But her trip had been to the Serengeti National Park. And that was pretty much it. And then she got admitted and actually started doing worse. And if you followed her white cell counts, they went down over time. And her platelets went down. And her hematocrit went down a bit. And so someone decides to get a smear. And this is what's seen in a smear. Any thoughts? Sleeping sickness. There aren't a lot of cases of sleeping sickness imported into the United States. But this one was. What's the problem if we don't treat sleeping sickness? What generally happens to people if we don't treat it? They die. Not a lot of infections that are uniformly fatal if you don't treat it. In general, we don't treat this. People do very poorly. I did have a couple of review slides on trypanosoma, on sleeping sickness. So it's T. brucei. There's Gambiense, which is West African, or Desiense, which is East African. West African, a little more of a subacute course, so it can take months for someone to really progress to the full sleeping sickness stage and ultimately die, but it's still just as lethal as East African sleeping sickness, which just occurs a bit faster for a period of weeks generally. West African sleeping sickness, oftentimes transmitted with the vector, tsetse flies, in the reservoirs, humans. And so it tends to be endemic, whereas this is more zoonotic because it's really game park animals and cattle that are affected with it. And so they serve as the reservoirs, and the tsetse flies give it to people. Now, I had read about sleeping sickness for years. Before I had seen her, I was very interested, have been for a long time, in tropical medicine. One thing I had always learned was you can always ask people that travel if they've been bitten by a tsetse fly. And if I was told, if someone has been bitten by a tsetse fly, they'll know it. Because apparently they're huge, it really hurts, they take a chunk of flesh when they bite, so it's not going to be a mystery. They'll say, oh yeah, I went on safari, and boy, I got bitten by a couple of tsetse flies, and they were terrible. So sure enough, the only case I see in my life, we asked her 12 times, do you remember being bit by a tsetse fly? She didn't know, I wasn't bit once. I was so careful I wasn't bit by anything. The second thing is you usually get sometimes something that looks like a local S-scar. This woman had no local S-scar. You usually also get local lymphadenopathy. She didn't have any local lymphadenopathy. So, there are bugs that read the book. West African and Eastern African trypanasomiasis kind of overlapping now, and it's more of a northwest to southeast kind of separation. And I just include this because I like to ask this question, because I think that's a joke out of it. All right, but this is true, and it's kind of neat. It's actually fascinating. When we get exposed to an infectious organism, what kind of antibody response do we initially have? We've never seen it before. I get infected with pneumococcus. I never had pneumococcus in my life, because I never leave my house. Now I get exposed to pneumococcus, because I go to the mall, and my initial antibody response is going to be anti-pneumococcal what? What kind of serotype? IgM, right? I initially make IgM, and then after a couple weeks, I will isotype switch, and I will make IgG, right? IgG undergo affinity maturation, and they can target better, right? So it goes IgM for a week or two, and then I make IgG. Here's something interesting about sleeping sickness. People with sleeping sickness, over a period of weeks to months, their IgMs are always elevated. Persistently elevated IgM, which is weird. Does anyone know why that happens? Antigenic variation. And there's a lot of ways that one can have antigenic variation, but the way sleeping sickness does it is the organism actually has hundreds of distinctly different genes that code for its outer coat protein, and all the trypanosomes will express one, And then every once in a while, one of them will just start expressing another one. And what happens is, let's just pretend they're colored. They're not really, but let's just pretend. So all your trypanosomes are blue. Well, eventually you start making a good anti-blue coat antibody, right? You start clearing it. But one of them just turns on another variable surface glycoprotein, and it's pink. And you can't recognize the pink. So you start making IgM to that, and as you start clearing that, another one started to make yellow. So it's always changing its outer coats, and that's one of the ways it can escape from our immune system. So they keep changing their outer surface protein. Basically, think of this organism as the Lady Gaga of the microbial world. Okay. But the genetics of it is fascinating. And so this is the local lymphadenopathy that's typically seen. As I mentioned, supposedly you get a chancre at the site, but you don't always. There was nothing ischemic or black where her initial site was. And you get regional replication in the cervical lymph node, and then it goes into the bloodstream, it goes to the liver, it goes to the spleen, gets into the CNS, and eventually, people have changes in mental status in the patient, they become lethargic, and they become comatose and die. And I'm not going to go into the details of treatment, but suffice it to say that it's very important to know whether someone has CNS involvement, and we do that by lumbar puncture. And if they have white cells in their lumbar puncture, treatment is different. And it changes, but a lot of times we end up having to use melarsoprol. And this woman needed melarsoprol. And this drug is very toxic. I think the toxicity of the drug confers something like a 3% mortality rate alone. And it's so toxic you can't give it through a peripheral IV because it'll melt it. So you have to get it through a central. Okay, so we'll do this case. 40-year-old, any questions? So, yes?
Do you have any issues with intracranial pressure in the patient?
No, she did very well. But you have to treat them for a while, and then you need to retap them a couple times over the next year to make sure it's truly cleared. It's the only case I've seen. I was actually working as a fellow at the NIH. It was my last year at NIH. It was 2005, and there were two of us that were seeing most of the patients, and my kind of co-trainee at the time. I mean, I was already an IV doc. We were both doing these postdoctoral fellowships. She took primary care of the patient after the patient left the hospital, and basically the patient just kept coming back. But she did really well. She only had a couple white cells in her CNS, but it was over 5, and so that meant indication to treat with melarsoprol. And it's nothing you really need to learn about in detail because it's a once-in-a-lifetime kind of case, and then you're going to be learning all about how to treat it. And then they're changing also sometimes what the recommendations are. Okay, so 40-year-old woman immigrated from Mexico. This you'll see this in the United States. We have a lot of this. She has the following on brain MRI. So what is this diagnosis? Neurocysticercosis. Okay, so here's my practical advice for cysticercosis. When you see this scan, how would you describe this? Someone describe for me. Someone raised lollipop person. How would you describe this? What does it look like?
Perforations?
Yeah, it looks like perforations or holes in the brain. Now, most patients with cysticercosis have seen their scans. And they're upset about them. I mean, legitimately, right? It looks like Swiss cheese brain. And that's upsetting. I would be upset if this was my brain. Here's the thing. You have to tell these people that they do not have holes in their brain. Patients are very grateful when I tell them this. They do not. What happened here was, so how they acquired this? What were they exposed to? They were exposed to eggs in any kind of food or water that was contaminated with what? Human feces, right? We get cysticercosis from eating eggs that are contaminated with the feces of someone that has tapeworm. We get the tapeworm by eating the infected meat of the pig. And so One can be a strict vegan, but if a person who prepares our nice spinach salad has microscopic eggs on their hand because they're carrying a tapeworm, then our strict vegan can get cysticercosis. So what happened was those eggs hatch, comes a larva, a hexacanth larva, it penetrates through the intestinal tract, goes up to the brain. But it doesn't directly eat brain parenchyma. It's not like it's feeding on the brain tissue itself. What it does is it goes into the interstitial spaces between the cells, and it'll eat the nutrients that are just bathing the cells, and it will grow outwards as a cyst. And what that is actually, this cyst, this is a tapeworm that is about to be. And what you have here is this thing called the head, right? So the inside here is the head. And I picked on the person with a lollipop because a lot of times people will say this looks like a lollipop inside of a cyst. So that's a description I've been given. Now, they'll say this is a scolex. It's technically not the scolex, because scolex means head of the tapeworm. This is a protoscolex. It is a head that is about to be. So if someone were to eat this cyst, this would evaginate, and that protoscolex would turn into the head, and the rest of that cyst would turn into the body of the tapeworm. There's a head, there's a neck, and then there's proglottic segments that go on down the intestinal tract. Now, unlike other cystic infections of certain helminths, this is not a pluripotential cyst. One cyst, one worm. So this is just a dead end for this person, right? And what happened was the cyst came up here, and it just starts growing outwards. You can think of this person as though their brain is a sponge, and someone took a handful of marbles and stuck it into the sponge. There's still the same amount of neural tissue there. How true is this? I'll tell you how true it is. I called a neurology consult on this patient. And this is one of these systems where we had to enter the consult into a computer, and then it prints out on someone's desk. And I knew the neurologist quite well because I was taking care of people with cysticercosis that had a lot of seizures, and I would consult for seizure activity. So this person called me and said, why do you need me to see the person? Are they having seizures? And I said, no seizures. And they said, they were busy. And this person said, come on, Ed, this is cysticercosis. You know it's cysticercosis. If they're not having it, why do you need me? And I said, well, here's the thing. I did, my ID physician neurologic exam on this person. She had about 40 lesions in her brain. They were everywhere. I said, on my exam, it was normal. She has a normal neurologic exam. And the neurologist, and I said, I don't believe it. And he said, well, I don't believe it either. I'll go see her. And then he did, his half-hour neurologist exam. So she had a normal neurologic exam. And the brain has a lot of plasticity. And this doesn't necessarily cause brain damage. Now, I don't want to oversell the fact that this doesn't cause brain problems. It does. But probably, it'll typically do it as the cysts die. And that's when cysticercosis causes problems. Because every time one of these cysts die, you get an inflammatory response. And that can lead to scarring. So first of all, that can lead to acute problems, right? So people will present with sudden death because they'll just get increased intracranial pressure, herniate, and die. That's a presentation of cysticercosis. But the other things that can happen is that sudden inflammation can trigger seizures, or it can trigger focal neurologic defects. And as part of that process, as you get scarring around these areas, you can get brain damage. And there was another patient I followed for a while, and we tracked neurocognitive decline in this person with careful cognitive tests year to year. She had a heavy burden of cysticercosis. So I don't mean to minimize that this doesn't cause any damage. It does, but it's not really holes in the brain. So this is cysticercosis. Her neuro exam is normal. Cysts are not equal to whole. This can cause seizures, headaches, focal neurologic deficits, hydrocephalus. There's a lot of cysticercosis in the United States, predominantly because we have a lot of immigrants. If you look at tropical infectious diseases and the number of hospitalizations in the United States and how much they cost us, it's just not even a question. This is number of hospitalizations, which it's in the black, so over 20,000 over this 10-year period, and the cost, I don't know what the number is, but this is in millions and this is in thousands, so this is a lot. So it's a problem. It costs the United States more than all other neglected tropical diseases combined. Do we need to confirm the diagnosis here? What do you think? Do I need to biopsy one of these lesions? This is too classic. There's actually nothing else. This is really pathognomonic for T-solium cysticercosis. If you only have one lesion and it looks classic, like let's say the rest of her brain was completely normal, but she just had that one lesion, can I say that's cysticercosis? You can't with one lesion. Just, who knows? It honestly could be a fast-growing brain cancer like a glioblastoma, and just necrosed in such a way that it looks like cysticercosis. There are also benign cysts of the brain. But when you have multiple, and you can see these protoscolices, then you're done. So it can be tricky. So multiple cystic lesions, each with a scolex, that's cysticercosis. Sometimes you can actually see it actually on retinal exam. You'll see it in the orbit of the eye. So that counts. And then tissue biopsy. And we do sometimes go to tissue biopsy. Here at Walter Reed in Bethesda, about 3 years ago, cases tend to come in clumps. We had 2 different cases of people that had worked elsewhere in the world for periods of time. Both of them came in with single lesion disease. Neither one of them looked like a classic cyst, but they had some cystic component. And both actually, one looked mass-like, one looked like it was a degrading cyst. Both were somewhat peripheral and pretty safe to biopsies as far as brain biopsy, never the safest thing to do, but they were pretty accessible. Both went to biopsy, and both were cysticercosis, and both were probably dying cysticercosis. They both got treated, but at that point, the treatment probably didn't add anything. The body was already getting rid of them. So cysticercosis is just a morphologic description for the type of cyst this forms. And a hint you can have is that a lot of times people have cysts at different points of development in their brain, and when they die, they'll form a granuloma, and then over time, that granuloma will turn into a calcification. So if you see cysts and intracerebral calcifications, that's also pretty consistent with cysticercosis. And when people present acutely, you'll usually see a large area of inflammation around the dying cyst. This is a woman I saw who did have a classic, this is just a classic cysticercosis cyst. She was 24, and you see she has inflammation around it. She presented with seizures. She was a Peace Corps volunteer, and just having generalized tonic-clonic seizures. She had several of them. And this was tricky, because she was 24, and apparently this area of the brain wasn't a great area to biopsy, because it was somewhat peripheral. There was a lot of discussion about what to do. And in this case, we were convinced enough it was cysticercosis that we went ahead and treated her for cysticercosis and followed her very carefully. And thankfully, this all disappeared over a period of about 6 to 12 months. It's not always so easy. A lot of times, if you follow imaging, you can get in trouble because it'll look better, but it'll look better because all the inflammation's not away and you're giving them steroids, and it just looks better, but the actual primary lesion is not improving, and that makes you nervous. The issue with the single cyst is what you can do to help out your diagnosis is get an antibody test, but antibody testing is only sensitive in patients that have a large burden of disease. With the single cyst, that antibody test will only be positive 50% of the time. And then like all antibody tests, it really just tells you about exposure. It never tells you that, well, that's really what it is. So it can be tricky. This is just for your learning pleasure if you want the slide set. And the treatment for cysticercosis is very complicated, and it actually is individualized per patient. I will say that in general, for most patients in the United States, we've decided that the benefits of treatment for most patients that have like less than 25 lesions, the benefits probably outweighs the risks. Whenever you treat someone in that acute period, there's a lot of risk for new seizures, for increased intracranial pressure, but the advantage is you know when it's happening, and studies suggest that long-term they'll have less seizure disease. So this is just some issues affecting how we decide what to treat. And then there's all these all these tricky issues, like do you give people anti-seizure therapy? Some people do it on everyone. I don't. I wait until someone seizes until I treat them. And then, do we give steroids? Today, most people in the United States will give steroids with it. There's some argument not to, because you get less absorption when you have less inflammation in the brain, there's less CNS penetration. But in general, we think people do better with steroids, so we'll give it. And then, like this was the same woman, and the issue here was she was pinching off her fourth ventricle. So she had this aberrantly large cyst. This is the same woman I showed you before. And so, so what would you want to do with this person, for example? She's about to close her fourth ventricle. Yeah, so I actually called the neurosurgeon, and I said, hey, can you put in a shunt in this person, and then we're going to treat her? And they said, come on, we're neurosurgeons. Shunt, we'll just take it out for you. And I said, you're going to take that out? You do neurosurgery? Isn't that a big deal? And you know, you have to talk to surgeons, because they know more than we do. And they said, you know, it's usually a big deal, but this is a posterior cerebellar lesion, and that's easy for us. And it was. I was like, really? And they're like, yeah, you avoid the shunt, we'll just take that out. I forget what he said. He said, we'll just shell that out. I was like, okay. But they did, and she tolerated it swimmingly, then we treated her. And she did really well. Okay, this is just the paper everyone cites. It's old now, it's over 10 years old. It's from the Garcia group in Peru. But they show that initially when you treat, everyone knows this, when you treat with anthelmintics, you increase the rate of seizures because you're killing the worms, you're causing inflammation. But over a 3-year period, you seem to have fewer seizures if you treat than if you don't treat. Because ultimately, each of those lesions is going to die. Every time one of them dies, you're going to get inflammation. Anyway, I'm going to stop there. This is risk of treatment versus benefits. There are some cases we don't treat. Like there's 100 cysts, you wouldn't treat. It's just too risky. And the cutoff number, usually once you get more than 20 or 30 people, will be hesitant to treat. And you don't treat dead cysts. Alright. Okay, this case is a brag. I'm going to brag. So you should know in advance, at me treat, bragging. So when you leave here, don't say, oh, that guy, he's so full of himself. Because I'm telling you. They asked me, I don't know how many hours. I gave 4 hours of lectures plus an hour of cases, entitled to one brag, right? So here's my brag. And I feel like I really helped this person, so that's cool. I graduated med school in '95, so I've been doing this for over 20 years now, right? And so I will tell you, I think this is like one of 2 people I've ever helped. So that makes you feel better, right? So it's like, look, this is one of my 2 that actually like did something for them. So, so there you go. So what's the story here? The story is, I did my fellowship training at NIH because I wanted to become specialized in tropical medicine with possibly not leaving the country. And that's a trick, but there are some places in the United States where you can get reasonable experience. I had no doubt that it's not the same experience as someone actually working in a tropical country, but I was also interested in doing a lot of bench work on malaria. So that's what I did. And then, of course, I finished my fellowship, my clinical fellowship, but then because I was interested in research, I stayed for another 4 years, essentially doing a postdoctoral fellowship in a lab. So I was an ID doc, I was board certified in ID and internal medicine, but essentially getting paid as a postdoctoral fellow. And then, you're married, you have kids, and they go to daycare, and your spouse is like, what are you doing with your life? And so, because I couldn't afford the daycare on a postdoctoral fellow, I couldn't, it was ridiculous. And so what I did moonlighting. And, 1 night a week, I would make the same amount of money as I made the rest of the week. And so I did that for over 2 years. I used to moonlight at a large local suburban hospital. And I have to say, other than being tired, I enjoyed it, right? Like, it was nice. You learn a lot when you moonlight. You learn a lot about different hospital systems and stuff. So on this stint, I was covering the internal medicine service, but mostly what I was doing was admitting patients into the hospital. So it was kind of like the advent of hospitalism. It was kind of covering its role as kind of precursor to a hospital service. And I get this patient, and I'm told, hey, this patient was told to go to the emergency department to be admitted. He's from Ecuador, and he's had a month of abdominal pain. And he had diarrhea a month ago, or 2 months ago, but it was just once and then it went away, so we don't know if it relates to the case. But he's lost 30 pounds over 3 months, and he always has an eosinophilia, always. And it's high. You remember a normal eosinophil count is anything below 500 cells per microliter? And he was always above that. It ranged from 1,000 to 6,400 cells per microliter. And he had been scoped. I think they had done push enteroscopy, and they even had small bowel biopsies. And this is what they saw. They saw, this is upper endoscopy, but I think it was like into the duodenum. And they saw an intent, I love this. I love this because my mother is a pathologist. And to me, this is just like encapsulates what pathologists do. I love pathologists. I know there's pathologists here. I'm not being a pathologist. But listen, because you send tissue to the pathologist, what do you want? You want the diagnosis. That's it. Like when I get tissue, like I convince like the pulmonary doc to get me a biopsy, right? Or the surgeon to cut something out. I think in the pathology, give me the answer. I am giving you tissue, right? So what do we get here? We get, this person has an intense eosinophilic and lymphoplasmacytic, I don't even know what these words mean, infiltration of the lamina propria with a marked eosinophilic leukocyte exocytosis along with a marked eosinophilic leukocyte infiltration of the submucosa. I feel like a dog listening to this was like, ba 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 ba, eosinophil, ba ba ba, eosinophil. I get it, there's a lot of eosinophils here. And then it's like, okay, so what is it? And now the truth is, this is a very fair reading, but it's funny. The differential diagnosis includes parasites, drug reaction, mucosal allergic reaction, eosinophilic gastroenteritis, Church-Strauss, and hypereosinophilic syndrome, amongst others. Not helpful to me. So, I think they had done 1 or 2 stool over and parasite exams, and they said, well, he's still suffering. There's a lot of eosinophils. We're going to bring him into the hospital for eosinophilic gastroenteritis, right? Which is a true disease process, and its prevalence is increasing tremendously in the United States, right? Are people aware? Eosinophilic, there's a lot of eosinophilic esophagitis, but there's eosinophilic gastritis, there's eosinophilic enteritis, and it's a real thing, and we don't entirely understand it, but it's excessive inflammation due to eosinophils, really in the absence of parasitic worms, in the absence of a vasculitis. People are trying to figure out what's happening here. So they said, well, this is what this person has. We're going to bring him in and give him steroids. Now, why was I worried about just giving this man steroids? Strongyloides. And I said, wait a second. He had a normal stool exam, but are stool exams great at finding strongyloides? No, even in the best of hands, really only about 50% sensitive if you do 3 stool over and parasite exams. And I forget, I don't think, he had a couple, but I don't think he had 3. And anyway, it's only 50% sensitive. And if I give him steroids and he actually had strongyloides, what can happen to him? He died. So they said, Ed, admit this patient, give him prednisone. And I said, get out. I said, listen, I don't think we should do that. I think we need to do a little more diagnostic evaluation, right? What would I get to see if he had strongyloides? A serology. And then if it was positive, what would I do? Treat him. And my other option, like if the internist I had spoken to said, and you're admitting this patient and you're giving him prednisone, what could I have done? I could have just treated, right? And I would have negotiated. I said, let me give him ivermectin. Why don't you wait a couple days and then you reevaluate? But the doctor I spoke to was very nice, very understanding. He said, well, if you're fine, like what you're saying makes sense to me. And I said, let me evaluate him as an outpatient. So we arranged outpatient follow-up with me. And then, here's the slick thing I did. This is slick. You're gonna say, oh, that guy's pretty slick. Because biopsies are not a good way to diagnose strongyloides. I wanted to do more stool over and parasite exams, and I wanted to get serology. But the next day, I called the pathology group that had his pathology samples. Because when people take biopsies, right, and they had taken like a dozen from this man, what do the pathologists have? They still have samples. They almost never process all the tissue, right? They do a few cuts here, a few cuts here, they look, oh, this is what we see. So I said, hey, listen, did you guys get a lot of biopsies? And the pathologist was really nice. They said, oh yeah, they sent us like 12 pieces. They just were biopsying everything and we didn't see anything. And I said, listen, I don't want you to do a lot of work. I don't want you to go through and read every one, but can you completely section every block you have all the way through and just toss it? 2 seconds a slide, because I want you to find a worm, right? And if a worm is there, it's going to be huge. So you can just glance at the slide and say worm or no worm. So, we did. I said, take the slide. This is not really what you do, but this is what we did. I said, pathologist, please find a worm, and there they were. So that was cool. And so then the patient came and saw me a week later, and I said, hey, I know what you have. You have strongyloides, and we treated him. And then he felt better. So that was a gratifying case, you know. But like I said, it's like 1 every 10 years, and you're good to go. That's all I know. I'm trying not to think of the cases, because there's also ooh, people I missed things on or did harm to, and I don't know where the balance is. All right. I'm trying to think what cases I have left, because I want to stop at 5 till. Are there any questions so far? Okay. I'm going to show this one really quickly. This might be the last one I have. I forget. I was cutting until 5 minutes before this talk. I have a lot of tropic cases. So this was a person who had been to the CAR, and he had been to Grima, which is a small village near the Ngoto rainforest, and on the southern part of the CAR. This is what that rainforest looks like. And he complained of recurrent swellings on his left forearm. This is an interesting case because of what happened to him. So this is someone who has recurrent swellings on his left forearm every day for a few hours, and he feels like it's sometimes moving. So what's that probably? Loa Loa. It sounded like Loa Loa. And so it sounded like Loa Loa. And the reason I like to present this case, well, so what do you need to know about CAR? Before you diagnose them with Loa, you want to say, is it there, right? And so I will see patients in clinic, and while they're sitting with me, I will pull up their countries where they were to find out, exactly what's there. And I use different different databases. I'll use the CDC website. I like Travax as well. I think you guys have access to it. It's really nice. I feel it breaks things down into a little more detail sometimes than the CDC travel site. And then there's the yellow book. I think it's really the yellow book. The yellow book's good too. But I'll look at different sites. Oh, what's there? Well, all major filarial infections are present in Central African Republic. How would we evaluate this traveler for Loa? What would we get? Okay, so we would get a serology. That's a great thing to do. And if this serology is negative, can I stop? You can probably stop. So you can kind of get a filarial serology and stop. Now, the filarial serology is going to take weeks to come back, to send out, they batch test it. So what else could I do? When would I draw his blood to look for baby worms? Do I do a midnight blood draw? No, I do a noon blood draw, because this is Loa Loa. That always comes up on tests. They like to ask you nighttime versus daytime. Loa's day, Uchuria and Brucia, the causes of LF, are nighttime blood. But for Loa Loa, you get a noon blood draw. And you can just do a smear, but it's better to filter, because then you can filter 1, 5, 10 mils of blood. So those are good tests to evaluate for it. And so he had microfilaria. It was low. Americans tend not to have high numbers. He had 3 per milliliter, but he had them. And he had eosinophilia, and his filaria serology was positive. And these are his MFs. They're pretty. And so the thing about him, I took this picture. I was proud of it. Not bad, huh? I couldn't get it all on one slide, but you can see the nuclei. It's nice. Okay, so, this is the worst question ever. What 2 conditions we have to ensure he doesn't have before we start him on treatment with DEC? And the answer is B. You have to make sure he doesn't have onco, and you have to quantify his microfood. So he didn't have onco. His MF counts were normal. And again, there's more detail in here than we want. But what happened to him was we treated him. 3 weeks of DEC. And then a year later, the problem with this case was he kept going back to the CA line. But he kept coming back with these angioedematous swelling. So his complaints, like he would report them to us. And we treated him again. And then 6 months later, I think this time without traveling, he got it again. This is what he told me. I had 2 swellings on my forearm. It looks like someone was poking a finger through my arm. And he still had an eosinophilia, but it was a little lower. And so we treated him like 3 times with DEC. And then we kept reworking him up because he kept going back to Africa. So how do I know he didn't pick up another worm infection? So we would do these full workups and not find anything, and then treat him. So he got like 3 courses of DEC. And then 6 months later, this happened again. And this gets frustrating, right? It's like, come on, like, we've treated you so many times. And so what's next? Well, eventually, you try something else. And it turns out that, I guess we gave him a total of 3 courses, and after his 3rd course, he did get better. It just didn't recur. But Amy Cleon did a nice study that showed that DEC, a 3-week course, doesn't always cure Loa. In fact, the first course only cures about 40% of people. And if you give a 2nd course, now just over half of people completely resolve their symptoms. And if you give more than 3 or more courses, you can achieve cure in 90%. And if it doesn't work after the 3rd course, you can try something else. So generally, you would try albendazole. So this is W.C. Fields, and I just like this quote. And he says, if at first you don't succeed, try, and try again, then give up. There's no use being a damn fool about it. And then, so we eventually try something else. But we knew he had Loa, wasn't the question. All right, and then this was the last case I had. And I'll just present the case. We won't go through the details of it. This is a 36-year-old man. I saw him here. I saw him here when we were, just before we turned into Walter Reed Bethesda. We were still at the National Naval Hospital. And he was in Uganda. And he said, I'm a CB. And I had been here for a few years. And I still didn't know what a CB was. Do you guys know what a CB is? Yeah, construction. Who knew we did this? And I'm like such a fool. I'm talking to this man. And I'm like, what were you doing in Uganda? And I swear, he goes, building bridges. And I said, oh, building bridges? And he goes, no, I was building bridges. So he had this presentation while he was in Uganda. So like, we have our troops are everywhere. They're doing all sorts of things. And he presented essentially with an acute febrile illness that looked like meningitis with severe abdominal pain. The only thing weird about it was he had an enormous eosinophilia. 63% eosinophilia. That's insane. In general, if you have an acute bacterial process that's making someone very sick, you get a very low eosinophil count. So the critical care doctor would even use eosinopenia as a marker for critical illness due to bacterial infection. He didn't have that. He had the opposite. So his story is complicated because he got rushed out of there. He was treated with all sorts of antibiotics. He was treated as though he could potentially have an abdominal catastrophe, as though he could have bacterial meningitis. He got ceftriaxone, amsulbactam, piptazo. He got treated for malaria, even though he was malaria severe negative. He got doxy, because doxy is good for everything. He got praziquantel, he got mebendazole. Eventually, he got better. And then I saw him in 2009. And again, this is right before we became Walter Reed, where we were still at the National Naval Hospital. And we saw him, his absolute eosinophil count was 8,000. So his main symptom, I should point out, was abdominal pain. So he had abdominal pain with a headache and some neck stiffness and an incredible eosinophilia, and he had been building bridges. What was it? Yeah, he had schisto. This was acute Katayama fever. And there aren't a lot of worm infections that cause high fevers. I told you filaria do cause filaria fevers, but but most of the time it's not a response to the worm. Sometimes it is, but usually it's due to bacterial superinfections. But acute schistosomiasis, what happens is a person gets exposed to the cercaria. The cercaria penetrate the skin. They make their way to the portal vessels if it's S. mansoni or S. japonica. And there they mate, yes? And you know, like the males, they hug the female, they live in copula their whole life, it's very romantic. And then after like 4 to 6 weeks, the female starts laying eggs. And those eggs are very inflammatory. The eggs are purposefully inflammatory. Why are they inflammatory? Yeah, because like those eggs are in a blood vessel and they want to get into the intestinal tract. So they actually use that granulomatous inflammation that they induce to weaken the structural walls of the vessel and of the intestinal lumen so they can get into the intestine. But sometimes a lot of those eggs get whisked away up the portal system to the liver where they get stuck in the portal triads and they induce inflammation. And when that first happens, we will present with a febrile eosinophilic response associated with abdominal pain. There's more data on this, and you can read through it at your leisure. But this was schisto until proven otherwise. And he had schistosomiasis. And then, of course, what did we do? Because he was working in Uganda building bridges, and he had schisto. So what do you have to do as a public health measure for your troops? What?
Check out everybody else was there.
Check everyone else. And so we called down, he was based out of Louisiana, and there was another person down there who had schisto, who was seropositive. And anyway, you can read more about this if you want. If you have questions, you can call me. All right, teaching points. Cysticercosis is complicated. It can be difficult to diagnose. And in most cases should be discussed with experts in the field to treat it. Always consider helminth infections in patients from endemic areas with eosinophilia. Rule out or empirically treat strongy in all patients from helminth endemic areas. I didn't make this point enough, but anytime someone has a fever, make sure they don't have malaria. I took out one of my cases that made that point. Acute schisto can cause high-grade eosinophilia, and filaria serology, is a good screen for filariasis. All right, thanks for having me. If you guys have any questions or anything, when you're out in the field or you're in clinics here in the United States and you want to bounce a tropical medicine question off of someone, feel free to call me or just email me. Always happy to talk about it. And thanks for all your time.